Thank you for allowing me to present my work today. My name is Abigail McGrory, and I will be talking about some early research from my master's thesis. This work is done through the, here we go. So this work is done through the Dalhousie School of Public Health at U of T under the supervision of Dr. Anna Heath. Okay, so a bit of background on the problem. Adaptive platform trials, or APTs, as we know from today, offer various benefits over randomized controlled trials. The benefit that we focus on is the fact that APTs allow for the evaluation of multiple interventions for a single disease. And this is really important because it prevents the need to run multiple clinical trials at one time. And this saves time, money, and allows the drug to reach the market faster. The most common approach to compare interventions is to find the probability that each intervention is the best. And we denote this p-best. REMAP-CAP and I-SPY2 are just some well-known trials that use this approach. However, p-best has been criticized when it's been applied to other research areas, such as network meta-analysis, because it does not take the full ranking distribution into account. With that in mind, limited research has been done to determine if p-best is the most suitable ranking method to use in a clinical trial setting, or whether alternative methods exist. And this is a really important question to ask because if we are going to stop a trial early and declare a treatment superior, we want to make sure that we have the best method to do so in terms of efficiency and accuracy. So our goal is to identify the best way to compare multiple treatments in an APT to save time, resources, and ultimately patient lives. So to find alternative ranking methods to p-best, I kind of conducted an unofficial systematic review where I found 16 significant papers with across multiple research areas, but with an emphasis on network meta-analysis. And that's just because network meta-analysis is also comparing multiple treatments across clinical trials. So it's kind of looking for a similar answer as us. From that, I identified 10 potential ranking methods, which I tested in R for feasibility and applicability to APTs. This narrowed down 3 ranking methods, which I compared to p-best through a simulation study. So here's kind of an outline of the ranking methods that we chose. At the top are the distribution of posterior treatment effects because we are doing the study under a Bayesian framework. So the first method is the pairwise method, which it's not necessarily a ranking method because it does take the distribution of treatment effects and it basically compares the actual values in a pairwise fashion. The reason we're considering this method is because it is the only method that takes into account the difference between the treatment effect values instead of the difference between the treatment ranks. So the other 3 methods here take the posterior distribution of treatment effects and convert it to a ranking distribution. So as I mentioned, p-best only looks at the, these bar graphs represent the ranking distribution. So this here we go. This dark blue area is the proportion of times that treatment is ranked first. The lighter blue area on top is the proportion of times that treatment is ranked second, and so on. So as I previously mentioned, p-best only looks at the proportion of times that each treatment is ranked first, and it doesn't take into account the rest of that ranking distribution. So this is kind of the problem that we are looking to address by looking at alternative methods. SUCRA stands for the surface under the cumulative ranking curve, and this is commonly used in network meta-analysis. It's essentially just a weighted average of the ranking distribution for each treatment. So in contrast to p-best, SUCRA does take into account the entire ranking distribution for each treatment, and that's why we are considering it. Finally, mean rank is similar to SUCRA in the sense that it also takes into account the entire ranking distribution. It's a little bit simpler as it just takes the rank of each for each treatment and then compares them based on that. Oh, sorry. Okay, so once we found our 4 ranking methods, we simulated an adaptive clinical trial and we applied the ranking methods to the simulations. And we use the results of those simulations to basically compare the ranking methods based on their performance. So this is just an outline of the simulation design. Our goal was to stop the trial for futility or superiority. This kind of graph is an example of the trial with 3 treatments, but we also simulated scenarios with 4, 5, 6, 8, and 10 treatments. The reason for this was just to see how well each method performed as we increase the number of treatments in the trial, because APTs are known to have a lot of treatments in the trial. So just to kind of go through this, in our simulation design, our first interim analysis occurred at 50 patients. And at this point, we applied each ranking method. And using that, we determined if we wanted to drop any treatments for a futility, if we wanted to stop the trial for superiority, or if we wanted to continue on with the trial. So if we continued on with the trial, we had 2 more interim analyses occurring at 100 patients and 150 patients. In this example, we dropped treatment 2, just to show you an example of how the futility works, but treatment 1 and treatment 3 continue on through the trial. So we ended the trial at our maximum sample size of 200 patients. And if there was more than 1 treatment left in the trial at this time, it was declared inconclusive. So here are some very preliminary results based on these simulation studies. We looked at 2 scenarios. So this is a superiority scenario. And in this, we basically assigned 1 treatment to perform better than the rest of the treatments. And we wanted to see how well each method could identify that treatment and stop the trial. So looking at these graphs, our power is basically the percentage of times that the trial declares the correct treatment superior. Our expected sample size was calculated as the number of patients in the trial at the time the trial concluded, divided by the number of treatments at the start of the trial. And as is the case in most clinical trial studies, we are looking to find the method that occurs kind of at this top left-hand corner that maximizes power and minimizes our expected sample size. So basically, these shapes here represent the power and sample size for the trial that that ranking method was applied to. So we have p-best, this is really hard, sucra, pairwise. Our pairwise D equals 0.1 is basically a variation on the pairwise method, just because there are many ways that you can kind of play around with it. So what we did was we added an extra rule to say a treatment could only be declared superior if it was significantly better than all treatment effects plus 0.1. So this is just kind of a more conservative method. Overall, it looks like from our graphs that p-best does perform better than all the other ranking methods in terms of expected sample size, because it does have the lowest expected sample size. However, all of the ranking methods do perform pretty well in terms of power. The other scenario was our futility scenario. And in this case, we selected 1 treatment to perform worse than all the others. And we wanted to see how well each method could identify that treatment and drop it from the trial. So power in this case is just the proportion of trials that dropped the correct treatment. In this case, p-best does perform better than all other ranking methods, both in terms of power and expected sample size. It consistently has a power around 90% for all of the scenarios, where the other ranking methods are below 80%. Okay, so overall, p-best performed well in terms of power and expected sample size for both scenarios. Although it's been criticized in other research applications, it performs well for APTs because it is answering the question we're asking, which is essentially which treatment is the best. That being said, we did identify alternative ranking methods that also performed well with similar power to p-best and expected sample size that was still below our maximum sample size. So these methods could still be useful in practice if we're looking at different questions. As for next steps, we want to extend to trials with non-normal outcomes and also increase the complexity of the trial design, for example, adding treatment arms during the trial or adaptive randomization. And that is it. Thank you.